Good afternoon, and welcome to What You Need to Know, New CALOSHA Workplace Violence Rules for Healthcare Facilities. This is Erin Mullenberg. I'm a partner with Arent Fox in the Healthcare Division, and I have the pleasure this afternoon of introducing our speakers. But first, just a couple of housekeeping items. I'd like to ask you to place your phones on mute during the course of the presentation. Also, during the course of the presentation, if you do have any questions, you will see in the right-hand corner of your screen a place where you can send us those questions in writing. At the conclusion of the presentation, we will try to answer as many questions as we can or as time allows. In the event that we are unable to get to your question, we will certainly try to answer it separately, or you can email us with the email addresses you see on the first slide. So our first speaker this afternoon is going to be Jonathan TAL, President and Chief Executive Officer of TAL Global. Jonathan TAL is the founder, President, and Chief Executive Officer of TAL Global Corporation. Jonathan is a veteran investigator and counterterrorism specialist with decades of field and complex management experience. TAL Global is an international security consulting and risk management firm that provides investigative and other security services, including disaster mitigation, as well as planning and risk management. TAL Global has developed a comprehensive program to help healthcare organizations build robust safety and security programs that comply with new CALOSHA guidelines. TAL Global staff has many years' experience in preventing and mitigating workplace violence for hospitals and clinics, major corporations, and the United States Postal Service. Following Jonathan will be Mark Drew, a partner in our labor and employment practice. Mark is the head of the OSHA group in Arent Fox's labor and employment practice, and is nationally recognized for his work in occupational safety and health law. Mark focuses on representing employers and trade associations in all aspects of the Occupational Safety and Health Act. His practice includes counseling clients in regulatory compliance with the standards and regulations which OSHA and the state plans have promulgated, investigating significant workplace incidents, managing OSHA inspections, contesting OSHA citations, defending employers in OSHA enforcement actions, conducting safety and health audits and due diligence reviews, and engaging in regulatory advocacy. Following Mark will be Oscar Villanova of TAL Global. Oscar is the Chief Operating Officer of TAL Global Corporation. He is an international security expert with decades of investigative, risk assessment and management, emergency preparedness training, and critical infrastructure security experience in the U.S. and around the world. Mr. Villanova has had a distinguished career as a federal security and law enforcement agent and as an executive in the United States Postal Inspection Service. In this capacity, Mr. Villanova led large-scale investigative security and law enforcement operations in several large metropolitan areas in the U.S., Europe, Africa, Asia, and Latin America. And then finally, we'll be hearing from Mark Phillips, who is also a partner in the Los Angeles office of Arent Fox. Mark is in the litigation and employment group. His work focuses on class action defense and labor and employment litigation, including suits for wrongful termination, defamation, discrimination, and wage and hour cases, as well as general commercial disputes. He also counsels employers on day-to-day employment matters and advises employers regarding new legal developments in the workplace. Jonathan, we would now turn it over to you to begin.
Good afternoon. Welcome to everyone on this Valentine's Day on this topic that's not quite Valentine. I am going to take control over here, and we are going to move to the first slide. And we're talking about workplace violence, and workplace violence particularly in healthcare. For some reason, the slide is not progressing for me. There we go. Oops. Okay, So let's start with a definition, and let me do a little bit of a history lesson. Workplace violence became its own discipline on a particular day. In fact, in 2 days from today, it would be the 29th anniversary of a rather gruesome event that took place right here in Silicon Valley. That is when Richard Farley has killed 7 people at ESL Corporation here in Sunnyvale. Following the unanswered infatuation that he had with his co-worker Laura Black. Richard Farley is spending the rest of his days in jail, but the event really led to significant enough attention that really created in the security and the human resources, behavioral sciences, and then legal professions, the attention on this phenomenon that we now call workplace violence. What is it? It's any incident that involves violence or the threat of violence. So, for example, when someone says, well, I don't like you and I'm going to do something to you, if in the victims or the recipient of this message, this is credible and it creates a fear, that is, in fact, a criminal violation of 422 PC here in California, and that would be workplace violence. So it really, if it's in the workplace or connected to the workplace, it will be workplace violence. It can occur either in the workplace or outside. Sometimes it would be associated with a personal relationship. It would be an estranged spouse, or it can be road rage that carries into the workplace. But it does involve the workplace as a component. It can range from anything from intimidation, threats, email, stalking, verbal abuse to an actual physical assault, and we'll go over some of those descriptions in a minute. The problem is significant. You can see that this is particularly prevalent in healthcare. The reason it is particularly prevalent in healthcare is because we do have an open environment. This is where people are supposed to come to be cared for, and it is by definition an open environment. It's also an environment where people are under significant stress, and as you can see, the numbers are quite significant. They're a little bit old here, but violent crime in 2013 was 2.5 incidents per 100 beds in a healthcare in a hospital environment. Healthcare workers are 16 times more likely to experience violence than any other workers, and that includes the 7-Elevens and the other places where violence is due to street crime, etc. Many of those are non-fatal, but clearly healthcare workers and cares and assistants and people that are involved here in this profession are very, very vulnerable. And I think this is why we're all here today, is because CALOSHA has a regulation following this, trying to respond to this vulnerability in some mitigating steps that are outlined in the regulation that will be discussed later on during this webinar. Forward here. Okay. Consequences, I'm not going to say much about this, but clearly those are emotional, physical, and performance-related consequences. There's significant costs associated with that, and those are some of the things that people experience. The employers have a significant cost associated with this as well. Morale, performance, damage to brand reputation. Every incident of workplace violence in the workplace is highly expensive. The average price is about $250,000 per incident, and that's over the multitude of workplace violence incidents across the country. So I'll tell you, I'll go through a couple of case studies, and then we can come back to those after the formal presentation with any questions if any of you would like to talk about those some more. This is a case here in the Bay Area with a well-known hospital. A patient was brought in on a 5150. He had a medical issue that was treated. He basically objected, but was not in a position to, was a situation where he had to get the treatment, was complaining that he caused him significant pain and suffering, which is something that's not uncommon in a hospital environment. And he came back after this treatment, and he targeted hospital administrators directly. He was very capable and very, very specific in his threats. And this required a ongoing monitoring and mitigation. He was 5150 a number of times, and eventually this situation went away, and we think he became another hospital's problem. And that's not uncommon, where people like this eventually move on to a different harassing and threatening behavior into a different place. The second case involves an insider, an anesthesiologist, who, among other things, put 2 pennies on his eyes, closed his eyes, put 2 pennies on it as if you do, or when you do when someone is a corpse, closed his eyes, took a picture of this, and sent it to his select group of people that he wanted to threaten with various messages. Then there were additional threats, including retaliation if they basically tell on him and his mistakes, his procedural mistakes. And he was terminated without an incident, but again, he was quite a problem for quite a number of people who then exhibited some of those symptoms and some of that stress that was described in the slide before. The last case involved a cardiologist. This is down in Southern California. He really was not doing his procedures according to the book, and had some serious violations, and was his privileges for practicing in that hospital were revoked. The chief operating officer received on his door a nailed, disemboweled rabbit as a sign, and followed with various threatening messages. This went on for several years, and this also was coupled with litigation, very extensive. This particular cardiologist actually enlists some of his former employees and nurses that worked with him to inform him of what was the hospital intended next step. And this eventually ended up successfully through very extensive litigation that finally made him stop. So those are some of the cases involving both insiders and patients that are typical. We handle an average of 100 cases like this a year, and many of them are in the healthcare, and we stand here to support you. I'll turn it over to Mark.
Can I get the control switch to me, please? Well, now we're going to go through the CALOSHA Rule, and this rule was really sponsored and had a lot of heavy involvement with some of the large labor unions, particularly the nurses union. And the final version that came out was approved by the administrative law judges on December 8th, and that version has a few revisions that are different than the others versions that came out. The effective date, this is April 1st of this year, with some staggered implementation. And in a very quick summary, it requires the development of a workplace prevention plan, pretty extensive training requirements, and pretty detailed record-keeping requirements. So the first is the definition of workplace violence. very broad definition. You know, it involves an act of violence, a threat of violence that occurs at work, and it doesn't have to necessarily result in an injury. It can occur if you have injury, stress, or psychological trauma, or if it involves the threat or the use of a firearm. And this rule really looks at 4 categories. You know, someone who has no legitimate business at a facility, say a gang member who comes to the emergency room in pursuit of another gang member. Someone who's a beneficiary, meaning a patient or a family member of a patient who reacts. Current or past employees, or the stalker case where someone who has or had a known personal relationship with an employee. And here, you know, it's pretty broad in its cover. It's covering hospitals, inpatient facilities, outpatient facilities, home health care facilities, paramedics and emergency services, drug treatment facilities. It's very broad. It doesn't cover things like workplace clinics. You run a factory and you have your own small clinic associated with it. You're not covered. A nurse's office in a school is not covered. Now, within the rule, there are about 6 sections that we're going to look at and talk through. The development of a workplace plan, the incident log you have to keep, you have to have a system to review the plan annually, you have to provide very effective training, you have to have certain categories of, meaning large hospitals and large psychiatric facilities will have a special obligation to report, meaning you pick up the phone, go online to report an incident of violence, CALOSHA, and there's going to be some pretty big record-keeping requirements. The heart of this will come down to developing an effective plan. And effective is really looking at, it's got 12 separate components, and you're really looking at it in terms of effectiveness of identifying potential violence hazards and implementing corrective measures, and then having some sort of review process. And when we go through it, you've got the obvious sort of things. You've got to have people who are responsible for implementing it. And then you need procedures to get active employee involvement in developing this rule. And what we really mean, what the rule is talking about here, we're looking at procedures to get employees to help in developing, reviewing, and implementing the plan, getting employees involved in identifying potential hazards and correcting them, getting them involved in developing the training and the reporting mechanisms. There also has to be a mechanism for the employers within a hospital or healthcare setting to coordinate between themselves so that the right hand and the left hand know what each other's doing. There's got to be a procedure to promptly notify law enforcement to call in or to get a hold of in the event of an emergency. You've got to have procedures for the employer to respond to the incident of violence, and there's got to be a non-retaliatory provision here where you can't retaliate against an employee who calls in the police. And then the procedures, you have to have procedures to make sure that all the employees, supervisors, managers, everyone is trained on this program and knows how to implement it. Now, you have to have procedures to ensure communication with employees regarding workplace violence. What the rule contemplates here is that the day shift can communicate important information to the evening shift and then to the night shift. If you're taking a patient, you know, from the orthopedic ward down to x-ray, that there's a way to communicate information to say this patient is difficult or violent. There's got to be ways to communicate it. Then there's a requirement, and this is one of the biggest things here, you have to have a set of procedures to evaluate and identify environmental risks. We're talking about some risks that are external to the hospital, say, what kind of, if you're in a bad part of town, what kind of parking do you have? What kind of lighting do you have? Are there barriers in appropriate places so that an angry patient can't lunge at someone? Are there ways that employees can get quickly to alarms or escape from an area? You also have to have procedures to evaluate any patient-specific risk, looking at what is the patient's mental status. Does he have an illness that is a tendency towards violence? Are there any drugs or medications that may tend someone to violence? And does the individual patient have any sort of history of violence? There needs to be pretty detailed procedures on how you're going to correct workplace hazards, looking at staffing, line of sight issues in terms can coworkers see each other? Is there an immediate access to alarms so if things get out of hand, you can summon help easily? And then what's the actual response plan? You have a problem in the ER, how do you immediately respond? And then lastly, there needs to be procedures to investigate workplace violence. And they have to be pretty detailed with the obvious things that you need to make sure that you provide immediate medical care, any counseling that might be available, and then to evaluate the response and the incident to see whether you can improve your plan. Then you have to put together a workplace incident log where you're looking at every incident, post-incident response, and investigation so that you're keeping all this information, and you have to keep it for 5 years. And it's going through the fundamentals of who, what happened, why did it happen, what was our response, what can we learn, and how can we get better. Personally identifying information, name, Social Security, phone numbers, that sort of thing, must be omitted. You have to put all this information together, but you also have to protect the confidentiality or identity of the individual employee. Then you have to review this plan that you've put together. It's got 11 components. You got to go through it at least every 1 year, looking at big questions. Is our staffing right? Do we have good security systems? Do we look at how a job is designed or the layout? Have we evaluated the hazards and the abatement measures in an effective way? Training, a lot of training here for employees. All employees have to get trained in an overview of the plan, the hazards, the corrective measures, and how employees can participate in the plan. For employees that have active patient involvement, they've got to get trained, refresher training every year. And the way this rule is anticipated and the way the procedures are written, they are really anticipating and wanting employees to participate in this process of training and improving the training. Then this rule only applies, one section of this rule only applies to general acute care hospitals and acute psychiatric hospitals. And there, certain types of incidents have to be reported within 24 hours. So if you have the use of physical force against an employee by a patient that results in an injury or high likelihood of an injury or stress, or any incident involving the use of a firearm or a dangerous weapon, they have to be reported within 24 hours. CALOSHA is planning to develop an online mechanism for this. Any other type of incident, meaning a threat or there's some physical force but no one has any injury or any stress, they would have to be reported within 72 hours. The record-keeping requirements here, pretty extensive. You have to keep this violent incident log, which covers the incident, the post-incident response, and the workplace investigation. All those records, you have to keep them for a minimum of 5 years. And then the training records for the individual employees and the refresher employees have to be maintained for at least 1 year. Now we'll transfer control over to Oscar.
Okay, in the next few slides, we're going to go over the process of conducting a gap analysis and developing a workplace violence program. As Jonathan said earlier, over the years, TAL Global has developed a proven methodology for providing workplace violence services to clients. And this methodology relies on the careful identification of potential risks and also on developing an understanding of the client's corporate culture. So to create a comprehensive and effective workplace violence program is really essential to maintain a viable view on the organization. The task of creating a program includes, as its first step, a comprehensive gap analysis consisting of an evaluation of an organization's current policies and procedures. I didn't take control. I will do that now. Didn't work the first time. Okay. And the existing regulations to find areas of improvement. Let's see. Something went wrong here. Oh. Okay. Sorry about that. So a workplace violence program is anchored to corporate priorities and the company culture to be embraced and implemented with a high degree of success. And the business environment, especially in a client-friendly organization like a hospital or a healthcare facility, must remain a very important part of any security protocols that are implemented. So,
Oscar, can you advance the slide?
Can you click on the presentation with your mouse?
That's what I was doing. There's a little bit of lag time.
There, thanks.
There we go. Okay, so the first step is conducting a gap analysis of the process. If there is one in place already, or otherwise, to find out exactly what the needs are for the organization. So it's important to, when conducting a gap analysis, to base the review on current industry standards and best practices, and also on the regulations as were mentioned a little bit earlier. And also it's important to have those individuals conducting the gap analysis have a bit of experience in this area, because it is really important to keep in mind prior cases, prior case law, and all of the different things that come into play here. So the process for conducting a gap analysis includes analyzing the current program, if there is one. It's probably the case that in a number of hospitals and healthcare facilities, there is no such program at the moment, and sometimes if there is a program, it could be a bit antiquated and perhaps hasn't been updated or is not used exactly the way it was intended to be used. So we need to take a look at the current program if there is one, and if not, what needs are there. And keep in mind during the process the specific regulations that CALOSHA has put in place, and also the level of compliance at the stage that we are conducting the gap analysis. Then that includes an analysis of written policies and procedures and other relevant information. What we're asking for is, where is the program now, and where does it need to be in the future for compliance purposes? One key element of this process is to conduct personal interviews with the appropriate personnel and key stakeholders. And the best information usually in any project that has to do with security or risk mitigation comes from talking to actual people who have been there, done it, they understand what the issues are, and they can provide a lot of really good information. Following interviews with individuals that have knowledge about the state of the security conditions at the facility, we then conduct an evaluation of the organization's current hiring practice. This is a great preventive measure when it comes to hiring new employees. If you are able to identify those employees that could potentially be an issue, if you identify them early on in the process, you can prevent a lot of issues. Another important step is to evaluate the corporate culture and its influence on past, current, and future protocols. It's not good enough to just put together a program. It has to fit appropriately to the organization's culture, wherever this place is, and where they are at the moment, and what their services are, and what their concerns are. We need to know the values of the organization, the priorities, and when it comes to this workplace violence program, it's really important to take that into account. Next, we do an analysis of the physical and personnel safety and security practices In other words, what sort of security do you have at the facility? What level of compliance you have in that area, and that includes internal communications, corporate communications that have to do with security and reporting events, especially when it comes to workplace violence programs. The final step in the gap analysis is to evaluate the current notification and response protocols. So we do all of that to get an understanding as to where the organization is in regards to this specific workplace violence issue. Once the gap analysis is conducted and is completed, we take a look at the findings and conclusions, and we document all of the findings and conclusions. And then we look for specific things. For example, whether there are any compliance issues per the CALOSHA standards and the best practices and standards applicable to this type of work. We also look for any potential areas or exposures or risks. We look for the capabilities and limitations of the current program if one is already in place. Again, some organizations may not have a program in place, but we have to look at this as well and consider it going forward. Another important factor is the potential corporate impact to all stakeholders, employees, contractors, clients, vendors, everyone else that's involved. And we have to also take into account the results of a comprehensive review of current policies and procedures, the current physical and personal security capabilities and limitations, and the result of any internal and external workplace violence threat assessment. These findings and conclusions are critical to the process and form the backbone of a revised program if one is already in place, or become the cornerstone of the creation of a new workplace violence program. So moving ahead, we are now going to talk a little bit about the next steps in following after the gap analysis, which is the development and putting together a workplace violence program. Again, we would follow industry standards and follow the regulations from CALOSHA, and we would look for best practices that are specifically tailored for successful assimilation into the organization's corporate culture. And in this particular phase of development, we would look for to develop a culture-driven workplace violence policy anchored in prevention and a zero-tolerance concept. The zero-tolerance concept has worked very, very well in other organizations. I came from the U.S. Postal Inspection Service, and as you probably know, the term going postal, we've had a lot of issues over the years in the Postal Service with workplace violence. One of the ways that this was resolved is by implementing exactly that, a zero-tolerance regulation within the Postal Service, and that helped a great deal because everyone is now aware that any kind of workplace violence issue, whether minor or major, will not be tolerated, and there's always consequences. In addition, in the development process, it also includes a patient and visitor-specific risk component and protocols on initial threat evaluation and follow-up. Continuing with the development of the program, part of the development will include putting together training for managers and supervisors to recognize and identify workplace violence issues. And this is very important, how to de-escalate and resolve conflict. And this needs to be done at the lowest possible level. Also very important as well is the development of a communication plan and a company-wide notification and response protocol. It's important for a number of reasons, but one that really came handy in my prior experience was that you can then analyze the type of events, and you can then plan ahead for what sort of prevention efforts you need to put together once you have knowledge about what has happened in the past. Employee orientation training is also essential. There really is no better time than when the employee comes to work at the organization to socialize them to the program and what the expectations are and how they can report any kind of event going forward. So it's really important to introduce also into this program practices in hiring for permanent, temporary, and contract employees. And
your line has been muted.
And when it happens, again, initially in the recruitment process and hiring process, it really helps prevent significant issues going forward. So moving to the next steps of the development phase of this, if one is not already in place, it's really important to put together an EAP or an employee assistance program and post-incident protocols. This has been proven to be very, very effective dealing with the after effects of a workplace violence issue, and it has also proven very effective at preventing, in many cases, workplace violence issues. I think it's important also to enhance the physical employee security practices in the organization or facility, and I think those have to incorporate a component that has to do with workplace violence. Security needs to be effective and adhered to by everyone for it to be helpful. There's also a need to provide guidelines and create protocols for liaison with external resources. Oftentimes, you would have a significant workplace violence issue, and of course, the first people you're going to call are the police, and they're going to respond. But if you don't have a relationship with police agencies in your area, then it becomes very difficult to get quick response or to get advice on certain issues if it's not an emergency. So it's really important to have a liaison and put together protocols for that liaison with external resources, whether it's psychological or police services. Also, it's important post-event to have an evaluation of what actually happened. This goes hand in hand with maintaining a record of these events, because one of the best things you can do after you have an event is to learn lessons from it so that perhaps you can keep it from occurring again. And finally, there has to be a system that has to be developed for incident data. Again, it's important to keep this information and record it accurately so that it can be useful in coming up with solutions going forward, and so that you can do appropriate reporting on when it happened, how it happened, who did it happen to, and so forth and so on. And the final point here is to develop methods to train and practice in new protocols. The value of any program that you get at your facility can only be realized if it's properly executed. That's really the key to all this work. And so tabletop exercises, yearly exercises with key personnel, and testing how they respond is really key to keeping the program effective going forward. So moving forward, we're going to talk now a little bit about the implementation and validation and support phase. Is the last part of creating the program, and this piece is critical to ensuring all the hard work to create a program delivers the intended results. It's no good to put it together if it's not implemented properly, if it's not validated, and if it's not supported. So during this phase, the program is implemented, tested, calibrated to arrive at an optimum level of efficiency and compliance. And in order to accomplish this, we need to provide assistance with the successful implementation of the program. So it's not good enough just to provide the program to the organization, but whoever puts the program together needs to be available to help implement it and to help provide advice to those that are going to be responsible for it. And then there has to be careful validation of the program by conducting after-action reviews, reviewing the program as necessary, and assisting with ensuring that compliance is targeted and is actually working in the form that the program is put together and implemented. Following that, then there has to be training in support of the implementation, and then the individuals that put the program together need to remain available to support the staff at the organization as necessary, again, to continue to make the program as reliable and as useful as it can be. And in this final graphic, you can visualize the entire process. it starts with a gap analysis, it goes on to program development, then it goes to implementation, validation, and then support. And provided that all of these steps are done correctly and the support from the key stakeholders is in place and the program is embraced by the organization, it should result in an effective and compliant workplace violence program for years to come. That's the end of my slides. Turn it over to the next speaker.
And Mark Drew will be taking over now.
This is Mark. I wanted to give you just a little bit of the implementation schedule within the CALOSHA rule. This is all covered facilities have to create the violent incident log and to begin maintaining the required records. So that needs to be done by April 1st of this year. In addition, by April 1st, you have to start with, keeping the records of these. So it's a fair amount of work there. Then if you are one of the larger facilities, a general acute care hospital or an acute psychiatric hospital, you have a special requirement that you have to begin reporting covered instances to CALOSHA. We had mentioned that before, that if you have actual use of physical force or the use of a gun or a weapon, then within 24 hours you have to begin reporting that to CALOSHA. So that's a requirement only for the large facilities. And then all facilities have to come into full compliance with the rule by April 1st of 2018. So you basically have a year to do your gap analysis, figure out how you're going to develop your plan, and do all of the extensive training that's required. So there are two small requirements that kick in for most hospitals by April 1st of this year. For the acute care hospitals and the psychiatric hospitals, they have a special reporting obligation, and then the balance of the rule is due a year from April of this year. If it happens that OSHA comes in and you're not fully in compliance, it's usually best, in my opinion, to sit down and explain to OSHA what you've done and have some sort of schedule for implementing what you're doing. OSHA generally looks pretty favorably on that if you can show that you have a plan, you're working, and you're on schedule. Then I'd like to turn this over to Mark Phillips.
In addition to the developing the plan and implementing things by the date, in the world of labor and employment law and in my own practice in both labor and employment and in the healthcare workplace, one of the things that we find is that workplace violence can come in both the expected ways and in very unexpected ways. And so, I want to talk briefly about some of the sources that violence and threats of violence can come from to be looking out for. In the world of security and whether it's national security or workplace security, one thing that security experts talk about is the danger of preparing for specific scenarios rather than staying vigilant for all kinds of scenarios. And in the healthcare workplace, we see threats of violence and violence coming from patients, from visitors, family members, employees, independent contractors, physicians, just about everyone could potentially end up being someone from which that comes or who becomes a victim of violence. So it's important to stay vigilant about that. In the patient world, we've seen the situations where a patient enters the hospital ER brandishing a weapon, threatening violence. Clearly an incident of threat and violence. The police are called, make an arrest, but the hospital ends up cited for an EMTALA violation for failing to conduct a screening exam on the violent individual as they were being put in the police car. So you need to be very open to creatively assessing situations and understanding what the various risks might be, and looking at it from as many angles as you can. Violence can also come from visitors and family, those who receive bad news about a patient, about a diagnosis, those who are unhappy about just the way that hospital staff are communicating with them. Drugs and alcohol play a huge role. And another situation that happens from time to time is violence that leads to someone being admitted to a healthcare facility, but the violence then follows them into the facility. Whether it's a bar fight that resumes in a hospital emergency room, or something else. Another thing that you need to be aware of and vigilant of is people who become disgruntled against an employee, against a staff member, against a physician, and who sometime later decide to take some kind of retaliatory action. This is not in the medical world and in the legal world, where as lawyers, I think we have more colloquial enemies than others. People don't like lawyers quite as much as they like doctors, but I've seen a situation where a disgruntled client of an opposing counsel, several months after litigation had ended, decided to try to retaliate against some colleagues of mine by delivering a gift of poisoned smoothies to the office in an attempt to poison the lawyers. Hopefully that doesn't happen as often with doctors, because doctors are not hated as much as lawyers are, but you need to look out for weird, creative things like that. If you hear people making threatening statements, be vigilant about that. And then violence by employees and other workers. Conduct that gives rise to employment actions often includes violence or threats of violence, whether explicit or somewhat less so. Sexual harassment situations often have inappropriate touching that can be perceived as correctly as violent interactions that a lot of people don't initially think of as violent, but that nevertheless are violent. When we talk about situations involving firearms or other weapons can be lots of things. I've seen situations in hospital settings where outside the presence of patients, employees got into a heated argument, and suddenly one employee grabs a bread carving knife from a kitchen drawer in a break room and holds it up, threatening another employee. That is that kind of a situation, and that kind of thing can come up unexpectedly, or if you watch for signs, maybe expectedly as well. And that's the end of my time.
Well, with that, we thank you very much to this panel, and we have a few questions that have come in, which we'd like to go over at this point in time. Also, if you would like to forward any questions to us, you can type those into the box down at the bottom of your screen, the bottom right-hand screen. But our first question here is, OSHA often refers in documents to the workplace. Is it clear that the workplace includes a location other than an employer's offices where a member of the staff is delivering services? For example, when a home healthcare nurse is visiting a client in the client's home, that home is considered part of the workplace for the duration of the nurse's visit. What about the journey to and from the client's home? Is that also categorized as workplace?